perhaps we'll get started. So welcome on behalf of the Respiratory Therapy Society of Ontario. We're super glad that you chose to spend some time with us today. Today we have the pleasure of spending some time with Dr. DiDiodato, who is a critical care medicine and chief research scientist at Royal Victoria Hospital in Barrie, Ontario. And he's also the assistant professor of the Department of Health Research Methods, Evidence and Impact at McMaster University. So I welcome you, Dr. DiDiodato, and thank you very much for spending your time with us today. Please note that the call will be recorded and posted on our YouTube channel after the broadcast, in the case that you have to leave and care for patients. And again, thanks so much, Dr. DiDiodato, for joining us today, and you're welcome to start.
Thank you, Paula. Welcome, everyone. Good afternoon. So I'm going to work through this COVID-19 vaccines update. I was asked by Sue Jones to consider giving a presentation. I had done an earlier one just before Christmas, but had to significantly update that version given how quickly things are moving in the COVID-19 vaccine world. So to start with, I just want to make sure that everyone realizes that anything I'm going to say today are my own views and opinions, and not necessarily reflective of the Royal Victoria Regional Health Centre or McMaster University. Since COVID-19 was first recognized in human beings way back in December of 2019, there's been a maelstrom of publications that are available for reading on COVID-19, estimates of somewhere between 100 and 200,000 peer-reviewed publications. So I'm going to tell you, I haven't read them all, and I don't think that I'm an expert in COVID-19. And frankly, I find it hard to be that there can be anyone who's an expert in the world on COVID-19. I don't have any conflicts of interest. I derive no financial benefits, nor ever have derived financial benefits from any of the companies that either make COVID-19 related medications or vaccinations. And so I'm going to give you a little bit of a background on human coronaviruses for those of you who don't know. This little picture of a scanning micrograph on the right is actually correct, is completely wrong. I just noticed it. It has red blood cells in the background of what presumably is a COVID-19 SARS coronavirus. And SARS coronaviruses are not viremic, so there shouldn't be any blood cells in the background. But anyway, it's an enveloped single-stranded RNA virus. There are 4 seasonal endemic coronaviruses that usually cause mild upper respiratory tract infections. There's been 1 epidemic SARS-CoV-1 virus, for those of you who are old enough like me to remember back in 2002 and 3. Another epidemic that's become an endemic coronavirus called Middle Eastern Respiratory Syndrome. And then, of course, we have our pandemic SARS-CoV-2 that has emerged in December of 2019. And just to give you a bit of a background of the 3 pandemic coronaviruses that emerged, all of them or 2 of them seem to have emerged in China, although there's some emerging evidence that people had been previously infected with SARS-CoV-2 even before December 2019 in places other than China. MERS is generally present in the Middle East. The historical, or the sort of what we call the ancestral hosts of these viruses all appear to be bats, but they have these intermediate hosts that the virus became jumped to. We think for at least SARS-CoV-2, there may be pangolins, which are sort of anteater-like mammals. The primary mode of transmission for all of them is respiratory droplet and contact. I don't want to get into a conversation about whether there's possible transmission via aerosolization. I will just say, of course, there's possible transmission via aerosolization, but we believe the predominant mode of transmission is via respiratory droplets. SARS-CoV-2, unlike SARS-CoV-1 and MERS, is predominantly a community transmission mode, and even predominantly within households. There are obviously nosocomial transmissions. We've had outbreaks in hospitals. In fact, the Royal Victoria Hospital has just had an outbreak in one of its wards. So we clearly see that it can happen. But unlike the other coronaviruses, it's mostly community-based. I just checked this morning, there were about 90 million people who've been tested and positive for COVID-19 in the world. The number of countries positive is 187. You can see that the scope of the number of people infected and the countries affected far exceeds anything we see with SARS-CoV-1 and MERS, and about 2 million people have died with a case fatality rate of about 2.2%, so much less lethal than either SARS-CoV-1 or MERS. So how does SARS-CoV-2 cause disease? Well, obviously, you need two things. You need a viral infection and then the host immune response to that viral infection. And what people have been talking about, I'm sure you're aware, is that coronavirus has these little spike glycoproteins on the outer surface of its membrane. And these spike glycoproteins have a receptor binding area for specific receptors in the human epithelial cells that line the oropharyngeal and respiratory systems. Once bound, they're internalized, and like all viruses, they have to hijack the machinery of the cell to replicate their genetic material into proteins and other molecules so that it can regenerate itself, reconstitute itself within a cell, and then they emerge from the cell and cause cell death. Now, in a normal response, in a person who has a healthy immune response, we see the production of neutralizing antibodies against the spike glycoprotein and specifically against the receptor binding domains, which prevent the virus then from attaching to the ACE2 receptors in the human epithelial cells. We see that the infected cells are rapidly cleared by macrophages and other immune cellular cells like T cells and B cells, and we see minimal inflammation and lung damage. But in those people who get catastrophically ill, and a lot of the people that you deal with in your hospitals and intensive care units, we see a dysregulated immune response. And instead of having a nice controlled clearance of virus and infected cells, we see excessive infiltration of not only immune cells, but excessive production of immune modulators. And this produces what people like to call a systemic cytokine storm, which results in things like pulmonary edema and severe pneumonia, ARDS, widespread inflammation and resulting in multi-organ dysfunction syndrome, so other organs become affected. And sometimes there's a propagation of further viral infection through a mechanism called antibody-dependent enhancement, where our own antibodies actually help the virus invade other cells. So that's the basic pathology and pathophysiology of coronavirus. And we know that we have it's caused a pandemic. And the question is, well, how do we control a pandemic? Well, the first thing that we have to understand when we have a pandemic is that a lot of people talk about what's called the basic reproductive number of viral infections. And this really represents the average number of secondary infections that result from an index case. And for SARS-CoV-1, we think that reproductive number is somewhere between 2 and 4, meaning that in an immune-naive population that's randomly mixing, we would expect, on average, somewhere between 2 and 4 secondary cases to emerge from a primary case. Now, when we intervene with non-pharmaceutical interventions, such as social distancing, wearing masks in public, or perhaps we have some drugs or vaccines or even changes in seasonality, what we want to do is reduce the number of secondary infections that occur as a result of that index infection. And the way to get a pandemic under control is we need to have an effective reproductive number somewhere around 1, meaning that only one other secondary infection will on average occur from exposure to an index case. So where is Canada's reproductive number now? So in the beginning, when we had a completely naive population, never exposed, as far as we know, to SARS-CoV-1, the estimated reproductive number of our coronavirus in Canada was around 3. And here you can see the trend of the estimated reproductive numbers that has occurred over time. And currently, it's estimated to be around 1.1, which in theory, you would think should be good enough to control a pandemic. But when you superimpose that on the number of cases of COVID-19, you can see that there's very poor correlation between the number of daily cases of COVID-19 and the reproductive number. At the start of the pandemic, you could see that our would appear to be a good correlate, an inverse relationship. As the R naught, the reproductive number, declined, our cases also came down as we would expect. And they remained low throughout the summer months and then started to pick up in the fall again. And when they picked up in the fall, there seems to be a complete dissociation from the reproductive number and the number of active cases. And so begs the question, one is whether we're actually truly detecting all the secondary cases. Almost certainly not. We know that our public health departments have been overwhelmed and truly unable to do all the contact tracing. So we have to suspect that the reproductive number that's been calculated is probably a gross underestimate of the true reproductive number, or there's some other thing driving the process. Okay, so things like super spreaders. So while the average reproductive number is 1.1, perhaps 10%, 80% of all infections are actually caused by super spreaders, people who can infect 20, 40, 100 people at a time. So, when we look at the non-pharmaceutical interventions, you can see the impact that the non-pharmaceutical intervention should have. So when you have a bundled approach, meaning you do things like limit size gatherings, social distancing, closing businesses, closing schools and universities, wearing masks in public, and now things like even stay-at-home orders as we should, in theory, if everybody was compliant, and which we know people aren't, we should be able to lower the reproductive number to a level at which we should be able to stop the pandemic. But the problem is when that doesn't work, what else do we have at our disposal? Well, if you look at all of the treatments and vaccines that have been submitted to Health Canada, you can see there's actually only 7 interventions or drugs and vaccines that have actually been submitted to Health Canada that are specific for COVID-19, 4 of which are vaccines, 2 of which have only been approved, Moderna and Pfizer. The Janssen vaccine, the Johnson & Johnson, and the AstraZeneca still have not been approved. Then there's Remdesivir, which some of you may have heard of, which is really a drug used to treat people with early COVID-19 infection that may reduce the time to symptom resolution, but really does nothing else in terms of preventing progression to severe disease or death. There's this monoclonal antibody that can be used in outpatients to try and prevent progression of disease. But we don't have a lot of treatments available to us apart from non-pharmaceutical interventions. So vaccines seem to be, our best hope at this point, along with being compliant and motivating people to be compliant with non-pharmaceutical interventions to control the virus. And of course, what we want to do with vaccines is to promote essentially a normal and regulated immune response, as I talked about, so that not only do we develop neutralizing antibodies that prevent subsequent coronavirus infection, but we also develop cellular immunity that can help combat the disease in those who are infected and minimize the severity of disease. There's a lot of different vaccine technologies that are currently being used and being tested in both phase 1, 2, 3, and 4 studies, and I won't go through all of them today, but the 2 most important technologies are the viral vector vaccines and specifically the non-replicating viral vector. Both the Oxford AstraZeneca and the Janssen vaccine use this technology. And then, of course, the DNA-based vaccines, the nucleic acid vaccines. Now, these mRNA vaccines are the Pfizer and the Moderna vaccines. Now, as most of you may know, there's no previously licensed nucleic acid vaccines, and so this is a brand new technology. They appear to be safe, although we're accumulating more and more data on people who have been in the studies and also people who are receiving vaccine in the real world. We don't believe the RNA gets integrated into the genome, so it's not long lasting. There's a transient expression of the protein that's expressed by the mRNA that's included in the vaccine. And the mRNA is metabolized and eliminated by natural cellular processes. The real advantage of these DNA vaccines is their flexibility. So as we see the emergence of mutant strains of coronavirus that may have the potential to evade our immune system, we can actually code for the DNA of those mutant viruses in a way that we might be able to create a vaccine or update a vaccine so that it's effective and produces an immune response that can combat mutant strains. As far as how many vaccines are in development, the WHO has listed that there are 63 vaccines in clinical development, meaning they're being tested on human beings, and 173 vaccines in preclinical development. There are about 15 vaccines in phase 3 studies, meaning randomized control studies, and 6 vaccines in phase 2-3 studies. And you can kind of see that there's a wide variety of vaccines using different technologies. But one of the important things is, well, how many vaccines actually have a one dosing schedule? And there's about 11 in development in which there's a single dose required only, but we don't have any approved at this point that are single dose vaccines. Health benefits of vaccines. I don't think it can be overstated how important vaccines have been to overall human health. It's believed that they reduce or prevent 6 million deaths per year, which equates to about 386 million life years saved. They've been responsible for the eradication of some infectious diseases such as smallpox, rinderpest, and polio, almost now completely eradicated except for in 2 countries. They're really important for people who cannot be immunized for a variety of reasons because they provide indirect protection through what we call herd immunity. They're also being developed to prevent cancers such as liver cirrhosis and cervical cancer. And they're extraordinarily cost effective. They're about $50 per life saved. So an unbelievable technology. Ideally, when we develop vaccines, we're looking for vaccines, one that can prevent initial infection. So they can sterilize the mucosal of your oral pharynx so that you never get infected in the first place. But if you do become infected, we'd like to see vaccines that can reduce shedding. That means reduce the disease transmission. And also we'd like to see vaccines that result in a humoral cellular immunity that prevents progression to severe disease and death. Now, what are the current endpoints for vaccines? Well, of the vaccines that have either been approved or submitted to approval, what you can see is that the primary endpoints that were initially developed so that the vaccines could essentially get emergency use authorization is prevention of symptomatic disease. So all of them certainly look at that as a primary endpoint, but none of them had been set up to look at reduction in severe COVID-19 disease or death, nor had they been set up to evaluate could they actually disrupt disease transmission. So we don't have a single approved vaccine at this point that's demonstrated that it can prevent initial infection of the upper airways, nor do we have a vaccine that's definitively been shown to reduce disease transmission from an index case to a secondary case. And unfortunately, we don't have an immunological correlate for what constitutes protective immunity, meaning if we give someone a vaccine, is there something we can measure in their blood, either their neutralizing
One moment, Dr. DiDiodato, we seem to have lost your audio. I'm just going to look and see to ensure that you're
it was
still.
me. I think I hit it by mistake. What
Okay,
was the
okay,
last
perfect.
I heard there? Was it? Hello?
Just the very beginning of
Okay.
we're just starting.
Sure. So the WHO developed sort of minimally acceptable targets for an effective vaccine before it should be approved. And these are consistent with other health regulatory bodies. Okay. So as far as the WHO is concerned, vaccines were not meant to replace non-pharmaceutical interventions. They were meant to be used as an adjunct to non-pharmaceutical interventions. That vaccines should be efficacious and acceptable to adults, including the elderly. They considered some exceptions acceptable, such as those who are immunocompromised. They obviously didn't want the vaccines to have any serious adverse events, so they needed to be safe and have minimal reactogenicity. They insisted that the vaccine demonstrate at least 50% efficacy based on randomized controlled trials that lasted for at least 6 months. And the efficacy could be in anything. It could be in preventing severe disease or death, minimizing symptomatic disease, minimizing disease transmission. And ideally, the dosing would be 1 dose, but up to 2 doses was acceptable. And the frequency of dosing needed to be more than 1 year. So in other words, they wouldn't consider vaccines to be useful if someone needed to be vaccinated, for example, every 6 months. So how do we measure vaccine efficacy? Well, the definition really means that what is the proportional reduction in the endpoint, whatever that might be, between the vaccinated and the control groups. Generally, this requires a randomized controlled trial, and it represents really the best case scenario for the direct effects of vaccines on endpoints. There's another important measure of how well vaccines work, and that's effectiveness. And this really is the protection attributable to the vaccine administered in the real world. And this includes both direct effects and indirect effects, that is herd immunity on the population. And for the most part, effectiveness is usually less than efficacy. Now, there's lots of challenges, as you can imagine, in trying to conduct a study in a pandemic. Obviously, people who live in different regions of the world have different exposure risks to COVID-19 that are related to geography, but also related to behavior. So, for example, you might have healthcare workers who are at much higher risk because of what they do compared to people who aren't involved in the healthcare industry. And then there's also issues around compliance with non-pharmaceutical interventions, which varies across populations. How many people do you actually need to recruit into studies to look at different endpoints? Well, a lot of it depends on what is the actual prevalence of disease in the place that you live. Participant characteristics. You would like a randomized controlled trial to include as many high-risk populations as possible that represent higher age or elderly, different races who seem to be at higher risk, marginalized or disadvantaged populations, people who have multiple comorbidities, immunocompromised, or even pregnant women, for example. There's lots of variation in outcomes regardless of whether you get vaccinated or not, that are due to healthcare systems. And so sometimes you might see differences in mortality rates that have nothing to do with the efficacy of a vaccine, but have more to do with how people are treated in the hospital system in which they live. How long do you observe people after your vaccination? Well, in the short term, obviously, you can look for adverse effects immediately after injection, such as reactogenicity or things like anaphylaxis. And you might be able to detect differences in symptomatic disease and maybe even in severe disease. But longer term, you get a better sense of vaccine safety. You get a better sense of how long does any protective immunity last, and also whether the vaccine is actually efficacious against infectivity, transmission, and death, which would be ideal. If we review the results, excuse me, of the 3, or at least the 2 vaccines that we have approved in Canada, the Pfizer and the Moderna, and then, of course, the AstraZeneca, which we have data for. We don't have data for the Janssen vaccine yet. As you can see that, and as we've sort of talked about, the Pfizer and Moderna vaccines are mRNA vaccines. The Oxford AstraZeneca is an inactivated adenovirus vaccine. All vaccines, all 3 are delivered intramuscularly. All 3 do require 2 doses. They've been tested in randomized controlled trials with 2 doses. For the Pfizer vaccine, for example, after you receive the second dose 21 days after the first dose, whereas with Moderna, it's 28 days, and the same is true for the Oxford AstraZeneca. When you look at the size of the studies, you can see they're massive. They involve tens of thousands of people. When you look at who was included in the study, there were a lot of exclusions, but basically the Pfizer group had the least restrictions. They had people over the age of 12. They didn't require you to not have been previously infected. But they didn't include people like pregnant people or immunocompromised people. The Pfizer vaccine was done in many countries because they wanted to demonstrate that the vaccine efficacy could be reproduced across geographic regions. The Moderna vaccine was only used in Americans. When you look at the distribution, or some of the distribution of people who were included, there was equal representation between males and females. The majority of people were white. For people who were non-white, there were smaller populations. And this is important because these are one of the populations, the non-white populations, that represent high-risk people for having severe disease and death. The Pfizer and Moderna group actually included a very large proportion of people who were over the age of 65, which was great, and it had at least one morbidity. The Oxford AstraZeneca was predominantly used in healthcare workers, so you had a much younger population, and so they were not as represented in the elderly. Now, as far as the endpoints went, the Pfizer group started to look at the proportion of reduction of disease in people starting at 7 days after the second dose. And to understand why that is, we'll have to look at the sort of the phase 1-2 studies that they did in healthy volunteers. So here we have a graph that shows what happens to people's immune systems, specifically their humoral immune systems, after they get vaccinated. So this was a dose-finding study done by Pfizer. So here you can see they used 3 different doses, 10 micrograms of vaccine. This was the 30 microgram group, and this was the 100 microgram group. And ultimately, they settled on the 30 microgram dose in the Pfizer vaccine. But here on day 1, because that x-axis is days, is when everybody got their first dose, okay? And you can see by day 21 in the 10 microgram group, there was a very little humoral antibody response, or what we call neutralizing antibody response, compared to what they were comparing the gold standard to was serum collected from people who had been previously infected with COVID, okay? So this is the level of neutralizing antibody on average from people who have been previously infected. And ideally, as a surrogate marker, that's what we would like to see happen in people who were vaccinated. So you can see on day 21 in the 10 microgram group, there's hardly any neutralizing antibody activity. There was a little bit more in the 30 microgram group, but not any more in the 100 microgram group. And on day 21, they were given the booster dose. And then by day 28, you can see a large increase in the neutralizing antibody activity. And so this was part of the rationale for them to consider observing how many cases of COVID could be reduced starting 7 days after the second booster dose. So the trials are still ongoing, okay? So the Pfizer trial was originally slated to last 26 months. So people who were originally immunized would be observed for 26 months. The Moderna was 24 months, and the Oxford AstraZeneca was 12 months. Most people were very compliant with both doses. So there's not a lot of data to know what happened in people who had only one dose. Just to sort of review the results, when you look at vaccine efficacy, okay, what they found in the Pfizer group, for example, for symptomatic COVID, there were 9 people who had symptomatic COVID of 21,669 compared to 172 people of 21,686, which equated to a vaccine efficacy of almost 95%. And when you look at the actual curves, okay, so this represents the cumulative incidence of people with symptomatic COVID disease. Here are the days. So day 0 is the first day that you got the first dose. And then they started following everyone at 7 days, 14 days, 21 days. And you can start to see that the curve starts to diverge at around 14 days, right? So this blue curve represents people who received the COVID vaccine, and the red curve represents the placebo group. And so you can start to see that by 14 days, the reduction in the number of cases or the vaccine efficacy was about 33%. By 21 days, the day that you received the second dose is around 47%, and the curves continue to diverge over time. Okay, so that's where they get the vaccine efficacy from. Moderna was just about as effective, and the Oxford AstraZeneca had some methodological issues, but on average, the vaccine efficacy was about 70%. In symptomatic COVID and those in the elderly, both the Pfizer and the Moderna vaccine showed about similar efficacy, which was very encouraging. As far as severe COVID went, they couldn't really say, Pfizer couldn't really say whether it had an impact on preventing severe COVID disease. Moderna also was sort of statistically not that significant, and Oxford AstraZeneca the same. So we don't have a lot of good evidence as to whether these vaccines do prevent severe disease. As far as the safety data, so the short-term safety data, the reactogenicity, systemic reactions, and severe adverse reactions, a lot of people had reactogenic disease, meaning they had symptoms at the site of injection, and sometimes they felt unwell systemically, fevers, malaise. As far as severe adverse reactions, the signals were not significantly different between the control and the COVID groups. There were no differences in deaths, and then just sort of some vaccine characteristics that you all know about in terms of the cold storage requirements of Pfizer, which limits its distribution, that are not the same for Moderna. So what does this all mean? Well, the question is, well, okay, I mean, it looks like the vaccines appear to have efficacy, but what does that mean in terms of how many people we have to vaccinate and how often to try and control the pandemic? And it's very complicated. The models are very complicated. But if you imagine a coronavirus that has a reproductive number of 2.5, that the number of people that you would need to vaccinate this does depend on the vaccine efficacy and then the duration of protection. So if it's true that the vaccine efficacy is 90%, and if it's true that the duration of protection lasted a year, we would still have to vaccinate about 90% of the population to really see good control of the pandemic. When you think about that and you look at Canada's population and you look at the target populations that have been listed by Health Canada as priorities, you can quickly see how many vaccines you need. So for priority group 1, Health Canada has recommended that we vaccinate all residents and staff of senior living and settings. Anybody over the age of 70, starting with those over the age of 80, people who are healthcare workers and direct patient contact, and then adults who live in Indigenous communities. That's the priority group number 1 in Canada. The second priority group are healthcare workers not covered in the first wave, residents and staff of shared living settings, and then essential workers. So, for example, in Canada, if you look at just the population of healthcare workers, physicians, and nurses, that's about 463,000 people. So you're going to need almost 1 million doses of vaccine just for them alone. If you look at people over the age of 80, you're going to look at around need over 600,000 immunizations. If you look at people with comorbidities, so in this age group, now you're looking at 6 million vaccinations. And then you start getting sort of the second age group, the second category priority group, you're starting to look at, tens of millions of doses of vaccine. So an incredible number of vaccines and vaccinations that need to occur. The question is, can we produce that much vaccine? Well, if you look at the projected vaccine production by the end of 2021, you can see here the different companies and their vaccines. So for example, for the Pfizer vaccine, it's projected that they might be able to produce somewhere between 1 and 1.5 billion doses of vaccine. Moderna, maybe 1 billion doses. Oxford AstraZeneca, which has the largest manufacturing capacity and distributed across 7 countries, maybe even close to 3 billion doses of vaccine. So that's their projected vaccine production. That's not, and that doesn't include if there are any supply side problems, if there's any shutdown of any manufacturing problems. Certainly, companies like Pfizer and Moderna vaccines are at high risk because they only have two countries in the world in which they produce vaccine. So they're very, very susceptible to having a problem in one of those manufacturing regions. If you look at how many doses of vaccine Canada pre-ordered, in all countries, many countries pre-ordered vaccine, Canada by far and away ordered the most vaccine per capita of any country in the world. They ordered about 9 doses of vaccine per capita. You might say, well, that's ridiculous. Why would they order 9 doses? Well, it's distributed across many different vaccines because they wanted to hedge their bets. So they purchased enough Oxford AstraZeneca, for example, to give 0.53 doses per capita, which obviously would not be ideal because you need to have 2 doses of the Oxford AstraZeneca. As far as the Pfizer vaccine they pre-ordered 2 doses per capita and 1.5 doses for the Moderna. This doesn't mean that they don't have the option of pre-ordering more. It just means that up front, that's what they pre-ordered in the hopes that as these studies came out and hopefully that they showed efficacy, that they would be the first recipients of vaccine coming off the industrial lines. With the amount of vaccine pre-orders that Canada did, assuming no problems with the logistical distribution and vaccination of people, assuming people would be willing to be vaccinated, it was projected that Canada would actually vaccinate all of the healthcare workers by the end of April, and that they would actually achieve essentially herd immunity by June, July. This is a projection, assuming that Canada could acquire all the vaccines that are pre-ordered, assuming that it could logistically distribute and vaccinate people at the rates at which they want to vaccinate people. If any of you are interested in the cost, Moderna by far and away is the most expensive. So $37 a jab with 2 jabs, so $75 US. AstraZeneca is by far and away the cheapest and probably will be the vaccine that's most widely distributed across the world. Other vaccine-related issues: how long will immunity last? Do we know what the long-term safety is of these vaccines? So post-marketing surveillance. Is there any impact on some of these genetic variants that are emerging on the effectiveness of vaccines? Are there other antibody or vaccine effects like antibody-dependent enhancement that might happen? And then, do we really know what the vaccine effectiveness will be during a pandemic? So how do we know that we'll have lasting immunity to SARS-CoV-2, whether that immunity was acquired through a natural infection or through vaccination? Well, if you look at how many people have actually been reinfected, while there are many different case definitions used, there are less than 100 cases reported worldwide. Now, having said that, almost certainly reinfection is likely underreported. But in those reported cases, the vast majority of reinfections resulted in a much more milder case. So that was encouraging news. Now, the implications of this is that if immunity is not long lasting, then social distancing and mask precautions may still be needed even after you've been primarily infected or immunized. With the possibility of reinfection and short-lasting immunity, herd immunity may not be achievable. And also that previously infected people probably need to consider getting vaccinated, because if it's not long-lasting immunity, you should be revaccinated. You should receive a vaccine. What do we know about the immune responses to SARS-CoV-2? Well, SARS-CoV-2, as I talked about, is not a viremic. Doesn't really have a viremic phase, meaning it doesn't really get into the bloodstream. And so the immunological response to viruses that don't get into the bloodstream are much less pronounced than those that do. And so they tend to last for shorter periods of time, from months to a few years. Now, we do know that there appear to be neutralizing antibodies to SARS-CoV-2. And what I mean by neutralizing antibodies, I mean antibodies that bind specifically to the receptor binding domain of that spike glycoprotein that clearly can prevent the entry of a virus into an epithelial cell. The neutralizing antibodies that people produce who've been primarily infected is directly related to the severity of the disease. So the more severe disease you have, the higher your level of neutralizing antibodies. But these may not correlate with antibodies present at the initial site of infection in the nose and throat. They seem to at least be present for at least up to 6 months, but the levels start to decline about 1 month post-infection. But this may not be as relevant because we know that the memory B cells that make these antibodies are present for more than 6 months after symptom onset. And this may be actually really important for the prevention of progression of disease and death. As far as cell-mediated immunity, which may be just as important or perhaps even more important than humoral-mediated immunity, we know that it's present for more than 6 months after infection. And this may be much more important at preventing infection at the mucosal surfaces, so in the nose and throat. This may also be present even in the absence of not being able to detect neutralizing antibodies. So you still may be immune even if you didn't have neutralizing antibodies to SARS-CoV-2. As far as monitoring for safety, Canada, like other nations, has a very robust system for post-marketing surveillance of vaccine-related adverse effects. And all countries have some kind of monitoring system. That in Canada, that responsibility is shared between Health Canada and Public Health Agency of Canada. And there's mandatory reporting by healthcare providers to report adverse effects following immunization, but this does depend on people approaching their healthcare providers and telling them about any potential vaccine-related effect. And we are collaborating with WHO to get a sense of, are there adverse effects following immunization that we're not seeing in Canada, but that may be present in other parts of the world. What do we know about early reports of adverse effects? Well, certainly with the Pfizer-BioNTech vaccine, there has been a higher incidence of anaphylactic reactions than we would normally expect with other vaccines, about 1 in 100,000 people, which is about 10-fold higher than most other vaccines. It obviously happens immediately post-immunization, usually within 10 or 15 minutes, and sometimes even earlier. All of them have responded to epinephrine. There's been no hospitalizations or death. And there have been new exclusions that have been sort of recommended, saying that anybody with a severe or immediate allergic reaction to any of the vaccine components, which can include the mRNA, which can include the residual non-human proteins, the preservatives and stabilizers, such as polyethylene glycol and polysorbates, that these people should not get the mRNA vaccines. Now, the problem is that the polyethylene glycol and polysorbate are normal excipients in a lot of other vaccines, and polysorbate is also used in the Oxford AstraZeneca and the Johnson & Johnson vaccine. So if you have an allergic reaction to polysorbate or polysorbate-like materials, these vaccines, especially if it's severe, you would not be a candidate to receive these vaccines.
Dr. DiDiodato, there's a question in our chat. Do we know the safety or recommendation of use with past history of Guillain-Barré syndrome?
There's no association with Guillain-Barré syndrome with these vaccines. So that should not stop you from getting these vaccines.
And what about if you have a history of GBS?
No. Guillain-Barré isn't like, you mean if you've developed GBS, let's say from a natural influenza infection, that shouldn't be that's not an exclusion to receiving these vaccines.
Super, thank you very much.
The impact of the emerging variants that many of you have heard about on potential vaccine effectiveness or even on natural immunity. So there's a growing concern that either our natural immunity acquired after a primary infection or vaccine efficacy might be compromised by these emerging coronavirus variants that you've heard about. Now, coronaviruses are interesting among their RNA cousins in that they have very low genetic diversity. And the reason for that is they have very, very large genomes. And because of that, they code for a lot of other proteins that most other RNA viruses don't code for. And these other proteins are actually proteins used to correct errors during the translation of genetic code to a protein. And so the mutation rate in coronaviruses is much, much lower than the mutation rate in other RNA viruses, such as hepatitis C or influenza. And so to the right here, imagine these pictures, these balls, the size of the balls as being the likelihood of having or developing genetic mutations. So hepatitis C is a very, very has a very, very unstable genome. It undergoes mutations all the time, which is why it's almost impossible to develop a vaccine against hepatitis V, because by the time you develop a vaccine, you have these mutant strains that can evade the immune system from that initial vaccine. But if you look at the relationship between vaccine efficacy and mutation rates, you can see, for example, Ebola virus, which has a little bit more genetic mutation capacity than SARS-CoV-2, the vaccine efficacy is very high. And as the mutation rates increase, the vaccine efficacy declines. So mutation rates, we know historically, do have an impact on the efficacy of a vaccine. And we don't, the other issue we have is we've not had enough time, or coronavirus hasn't really had enough time to undergo significant amounts of mutation since it's emergent in human populations. But as far as we know, there's no real world evidence yet that there are infections due to immune evasions from some of these variant coronavirus species. We've seen recently that there's been a global emergence of specific coronavirus, which has been a strain which is called B.1.1.7, initially detected in the UK, but now spread globally across the world. And there's also another mutant variant that's emerging in South Africa called 501Y.V2. It's believed that these have increased infectivity and may be responsible for some of the increases in cases that we're seeing more recently. These two specific strains do have many mutations within the spike glycoprotein, and they have a common mutation in the receptor binding domain of spike glycoprotein, which is what we don't like, because that may have an impact and may improve their ability to bind to the ACE2 receptor in human cells, which may explain why they're much more infectious. As far as the implications, again, the concern is, will these strains evade natural or vaccine-stimulated immunity? For the studies that have been published so far, it doesn't appear, at least for the B117 strain, that mutation or those mutations confer the ability to evade our immune system, so they still seem to be susceptible to our immune system. However, there is another mutation in the South Africa strain that's in the receptor binding domain that is suggestive that it may, in some people, be able to evade their immune systems, which is obviously a concerning development, especially if that becomes more widespread globally. Vaccine-related antibody-dependent enhancement is a weird phenomenon associated with humoral immune responses, initially recognized in the 1970s. And what happens is that people sometimes develop antibodies to infections, but these antibodies are not really good. They're not very neutralizing, or they're at very low levels. And what they actually do is they interact with the virus to promote its uptake into epithelial cells. So they have this paradoxical effect. They actually promote infectivity as opposed to prevent infectivity. And this can result in much more severe disease. And so our vaccines are all developed against the receptor binding domains of the spike glycoprotein, and in a sense to ensure the promotion of the best neutralizing effect. And as far as we can see, there's been no evidence of antibody-dependent enhancement after vaccination in our studies. Now, how effective is a vaccine during a pandemic, right? It's one thing to give a vaccine to someone in an endemic setting, but what impact does a pandemic have on vaccine effectiveness during a pandemic? Well, we know that there's a real-world discount to vaccine efficacy that we see in studies. And this efficacy may be dependent on the ability of vaccine to prevent infection in the first place, prevent transmission, prevent disease progression, or a composite of both. How effective it is depends on how many people we vaccinate, and that depends both on the pace of vaccination, meaning what percent of the population is vaccinated in any given day, and on the coverage, meaning the cumulative proportion of people who are ultimately vaccinated in the population. And also on the pandemic phase. When you have a pandemic phase that's out of control, meaning you have a high effective reproductive number, the effectiveness of a vaccine dramatically reduces, okay? Now, the good thing in Canada is that the most recent Ipsos Reid poll, or I think it's Angus Reid poll, showed that more than 80% of Canadians appeared to be willing to become vaccinated. 60% ASAP, I'll get vaccinated today if you give me the vaccine. And another 23% say, yeah, I want to wait a bit, probably because they're concerned about longer term effects, but I will get vaccinated. And you can see that that number seems to be increasing. So the number of people, for example, in early December who said yes right away has increased, and the people in the 31% group are the people who are moving now into, yes, I want to get vaccinated. And it's important because the coverage, the proportion of the cumulative proportion of people in the population who get vaccinated is directly related to our ability to achieve herd immunity. And herd immunity, what we mean by that is the proportion of the population that must have protective immunity to end disease transmission. And this is how we estimate herd immunity. But generally speaking, we would need somewhere between 50 to 70% of people in the population who have 100% protective immunity in order to, if you will, stop the pandemic. Now, what you've also recently heard is that efficacy can also be affected, obviously, by how many doses of a vaccine we get compared to what's been tested in a study. And in the UK, because of pressures around supply, that is, the supply has not been able to keep up with the demand. In the UK, they've introduced recommendations around delaying the second dose of the mRNA and even the viral vector vaccines to saying, after you get the first dose, unlike in the trials where the second dose was given either within 21 days or 28 days, they're making recommendations that you can wait up to 12 weeks from the first dose to receive your booster dose. And the rationale has been, look, we don't have enough supply to keep up with demand. There's been a rapid increase in COVID-19 cases, especially with the emergence of these mutant strains. There's supply limitations. And we know from previous experience that the first dose is the most important dose for protection. And yes, it's great to have a booster dose, but it's not the be all and end all. And so they did some evaluation of, well, what is the real vaccine efficacy of the Pfizer, of the Moderna, AstraZeneca vaccines after receiving just one dose? And when you hear in the news about that maybe one dose is almost as protective as the two-dose regimen, this is how they've come to that conclusion. They did a little bit of statistical gymnastics, but bear with me, okay? So here's the curve that I showed you before for Pfizer, right? The number of people who got symptomatic COVID is the blue line. The number of people who got COVID is the red line for the placebo group. And here are the vaccine efficacy that was reported in the study. But what they did is they said, hey, look, we would never expect a first dose of vaccine to have any impact until about 10 to 14 days afterwards. It takes that long to start developing protective immunity. But so we should really start counting how protective these vaccines are at 14 days onward. So what they did is they said, okay, well, how many people got COVID from day 14 to day 21? Because they figured, well, that's really the protective effect of the first dose of vaccine. And what they saw here was that only 2 people in the vaccine group versus 18 people in the placebo group got COVID between 14 and 21 days. And that equated to a vaccine efficacy of 89%, which, if you remember from the initial slide, the overall vaccine efficacy that was estimated for the Pfizer vaccine was 95%. This is where they got that number from. Okay, and so this is the sort of the reanalysis of the original study data that they're using to justify the recommendations of delaying, if you will, the booster dose of vaccine. Okay, and so when you look at their estimates of vaccine efficacy after just one dose, these are the numbers, okay, that they're publishing, saying this is the efficacy if people just receive one dose. So for Moderna, they estimate 80%, and for Oxford AstraZeneca, they estimate 73%. So not a lot of difference between what they're saying is one dose versus a 2-dose regimen. There's lots of controversy around this, and there have been many responses, both for and against this, and I won't go through this, but there are. We're getting to the last couple of slides, and I would say this. This is probably the most important, these 2 slides are the most important slides of the presentation because they really demonstrate the impact a vaccine can have in the context of a pandemic, okay? So let's just go through this. This scenario assumes that 0.5% of our population is being vaccinated every day. And in Canada, that would equal 185,000 people a day. It assumes that at least 50% of the Canadian population will become vaccinated, okay? These are the scenarios for the different reproductive numbers, right? We're probably in the part of a pandemic where our reproductive number is around 2. Remember that the initial slide that I showed you that suggested the reproductive number was around 1.1. But despite having that reproductive number, we have an exponentially increasing number of cases. So we're probably around here. These are the different efficacy endpoints of the vaccine. So let's imagine we have a 90% vaccine that's 90% effective. So in this scenario, and I'm going to focus on these 3 columns here, imagine a vaccine that had both the ability to prevent disease transmission and also a vaccine that could minimize the severity of your disease or prevent death, which is this composite vaccine. So in a situation where we have a pandemic that's still out of control, we're vaccinating 185,000 people a day. Even with the vaccine, we might be able to reduce the number of infections by only around 40%. And that's assuming we're still doing all of the non-pharmaceutical interventions. So you can see that the efficacy of a vaccine in the real world is very, very dependent on what state of a pandemic we're in, okay? And the sort of the ability to vaccinate, or the time required to vaccinate people in terms of pace and coverage. So if we said, okay, we were vaccinating people at a 0.5% pace a day, which is what we were doing in 2009 with the pandemic influenza vaccine, and we want 70% of the population covered, it would take about 175 days to actually achieve that goal. Now, if you look at, well, okay, how many people are we actually vaccinating a day? Are we meeting that 185,000 number? Well, here you can see the number of people vaccinated every day in Canada. And what you see right away is the most we've ever been able to vaccinate up till now is around 42,000 people. So if I said it took 175 days to vaccinate 0.5% at a 0.5% pace of 70% coverage, which is what we really need to develop herd immunity, 42,000 people would mean that it would take about 4 times. So it would take about 2 years if we only vaccinated 40,000 people a day to achieve herd immunity, which of course is an untenable situation. So ideally, right, what we want from these COVID-19 vaccines is we want them to be safe, right? We want to minimize the number of injections we have to get. We want the efficacy to be as maximized as possible, but we have to then also do our part in terms of continuing to be compliant with all the non-pharmaceutical interventions that are being suggested, including things like lockdowns, including things like school closures, which have profound implications in other parts of our health and well-being. And hopefully that'll lead to a situation where we can minimize the overall burden of non-pharmaceutical interventions over time. So that's the end of my presentation. I know it took a very long time. I apologize, but there's a lot of material to cover. But if we have some time for questions, I'm happy to answer them.
We do have some questions. I'm just going to read them out here. Just looking at the conversation. What would you say to patients that question the long-term effects of the vaccine? Sorry, did we lose audio? Dr. DiDiodato, the question is, I'm not sure if you can hear me or not, but the question is what will you say to patients who question the long-term effects of the vaccine?
Can you hear me okay?
I can certainly hear you. Are you able to hear me?
Yes, I can hear you. Yeah,
okay, super.
So for the mRNA vaccines, the Pfizer and the Moderna, these are the very first 2 DNA-based vaccines that have been licensed. And so while we think they're generally safe, we don't have any long-term data in other diseases or populations in which vaccines of this type of technology have been used before. So it's reasonable to wonder, do these vaccines really have any long-term effects? And honestly, I don't think anyone can answer that. They appear to be reasonably safe, given that they're very short half-life in the body. But I mean, until we do these studies, until we complete the studies that have been planned, and until we do post-marketing surveillance, it's going to be very hard to know about the mRNA vaccines in terms of any longer-term side effects that they may have. But having said that, COVID itself and COVID infections, there is a syndrome called long COVID, right? And we know that there are sequelae of having a COVID infection, which can last for a very long time and can be quite debilitating. So like anything else in life, it's a trade-off, right? There's always trade-offs to be made.
That makes sense. Thank you for that. The other question we have is 40,000 per day. Do we have an idea of when and how that will increase to what we need?
I'm not involved in the logistical distribution of vaccines, and I mean, it must be incredibly difficult, as you can imagine. First is, there are obviously issues around the cold storage requirements of Pfizer, but hopefully as we acquire more vaccines like the Moderna vaccine, and perhaps how Canada will improve the AstraZeneca and even the Johnson & Johnson vaccine, opportunities for vaccinating people will hopefully increase. But until that time, I think these are just natural limitations. I mean, it's an endeavor to sort of, set up a distribution system that can, vaccinate, 200,000 people a day.
Right, which is quite, I guess, it sounds very challenging anyhow. The next question is it important to have the same brand vaccine for the second dose?
It's a great question, and people have been asking that question. Nobody really knows. I mean, each of these vaccines have an antigen that promotes a very specific humoral antibody response. So the piece of mRNA that codes for the spike protein in the Pfizer vaccine is different than the piece of the mRNA that codes for the spike protein in the Moderna. But the presumption is you would think that the receptor binding domains should conformationally and chemically look almost the same. But would that have enough of a different impact that, let's say, giving a booster dose of a Moderna to someone who received Pfizer will actually boost the immunological response? I don't think we know that yet. I just don't think we know.
Okay. Thank you for that. I think that clears that question up. Great answers and great questions. Any concern that the virus will become resistant using only one dose in high community rate?
Again, a great question, because even though coronavirus, unlike the other RNA viruses in its family, undergoes slower mutation rates, nonetheless, there will be mutants that emerge, and they may become dominant strains, and they may be selected because they're able to evade either natural immunity acquired during infection or immunity acquired after vaccination. So it's possible that having an incompletely immunized population will select for the emergence of a more infectious or more lethal strain. Or if you're incompletely immunized, meaning you have antibodies, but not at levels that completely can control all the virus, so that some virus is able to evade an incomplete or partial protective immunity, then you might select for viruses that can spread more globally, that can evade immune systems.
Okay, great. Thank you for that. We have one more question so far. Any studies on safety of vaccine for people who are immunocompromised, for example, Addison disease?
I think the problem is not so much that the vaccine's not safe, because these are not live viruses, right? There's I think only one vaccine in development for COVID that's a live attenuated virus. The rest of them just contain bits and pieces of a virus. So there's no risk of giving any one of these let's call them inactivated vaccines, for lack of a better term, or non-live virus vaccines to immunize people in terms of promoting an infection. And that won't happen, obviously, because the antigens are not live viruses. They don't depend on live virus to promote an immune response. The issue will be will the immunocompromised person develop sufficient protective immunity, one, to prevent a primary infection, and two, to make sure that they don't develop an antibody-dependent enhancement effect that I talked about, which is they don't develop either enough antibody or the immunity they develop actually promotes infection in an immunocompromised person. So that's the real issue to answer about immunocompromised people. It's not so much that they'll have a coronavirus infection as a result of vaccine administration. That won't happen because they're using non-live or antigen specific vaccines. It's whether they'll respond to the vaccine in the way that we need them to. One, so that they don't get infected. Two, to prevent antibody-dependent enhancement effects. Yeah.
Okay, that makes sense. Thank you. We also have a question about the safety for those who are pregnant or breastfeeding.
Well, coronavirus is not doesn't have a viremic phase, right? So as far as we know, there's never been any, as far as I know, so 200,000 papers and counting. As far as I know, I've not seen any papers that suggest there's ever been any evidence for vertical transmission from a mother to a baby in utero, okay? Which means that unlikely coronavirus will be in breast milk, because if it's not, doesn't have a viremic phase, which is how it gets to a baby in utero and how it gets to breast milk, that shouldn't happen. So if coronavirus doesn't have a viremic phase, there should be really no reason why we would expect, let's say, immunizing a pregnant woman who's, or sorry, a postpartum woman who's breastfeeding would pose any danger to the baby. Okay. So I don't think for breastfeeding women that there's any danger in getting any of these vaccines. And that's been the recommendation in general that's now emerging from advisory committees for immunization that have experts on them that say, yeah, breastfeeding women should absolutely get vaccinated. For pregnant women, we don't, again, have any history of the use of mRNA or DNA virus technology in pregnant women. So it's much harder to know what impact potentially these vaccines could have on pregnant women. We do have, hopefully, like the Oxford AstraZeneca vaccine, while not like the influenza vaccine, uses kind of a similar technology. And so one would wonder, it should be generally safe to use in pregnant women, but that requires a discussion, obviously, between their physician and the pregnant woman. There's been a call to include pregnant women in these studies for this very question, because it leaves pregnant women kind of in the lurch, not knowing what to do. But also, I would say, for those of us who can get immunized, therein lies where we can help people who are, for example, immunocompromised or pregnant, because hopefully in immunizing ourselves in sufficient coverage, we should allow for some herd immunity to protect people who are either not fully immunized, or not fully protected, or unwilling to get vaccinated because they just don't know what the long-term or even short-term ramifications are, either to themselves or to their unborn child. So for breastfeeding women, yes, get vaccinated. For pregnant women, it's a conversation to have with a physician and the patient.
That's great. I think Vicky has a question. I'm just going to unmute your line, Vicky, if you want to ask. One moment. Vicky, go ahead. I'm gonna maybe move to another question while we get Vicky live in action, if that's all right. Sorry about that. Do you think that this vaccine will be required for children at school unless they have a valid exemption?
I doubt that the vaccine will ever be mandatory. I think it's probably a politically untenable position to take. Although I guess if it became a public health mandate, it could be that you would need, sort of to have an immunization passport to gain entry into school. That might, who knows if the pandemic continues to spiral out of control. Public health does have the legal authority to do things like that, right? They could restrict freedoms, and part of restriction of freedoms can be mandatory immunization. But I just don't think that we're close to that at all. I would say that as a parent, I mean, honestly, it would make sense to me to have children immunized. One, it hopefully allows them to go to school sooner and get socially more engaged and be able to do the things that children need to do for their overall health and well-being. And two, especially for colleges and universities, where there's a lot of risk because older teens and adults seem to be more infectious or more likely to be infected than younger children in elementary school. I think it's really important to get college and university students back to school too. So I think I would just say that vaccination offers an opportunity for us to hopefully return to normal sooner. And unfortunately, all of us, I think, are going to have to participate or do our part to do that, and I think that means children getting immunized, even though, unfortunately, they were not included in the studies, and that's a real tragedy.
I agree. And are the two vaccines that are available right now they're only for children greater than 16?
Yeah, so Pfizer actually enrolled some children over the age of 12. There wasn't a large group, but it seemed to be safe. They didn't include the results in their final analysis. The Moderna and the AstraZeneca Oxford vaccine excluded anyone under the age of 16. Or was it 18? I can't remember now. It was either 16 or 18. Yeah.
Okay. Another question, do the timelines for herd immunity take into consideration the percentage of the population that becomes immune due to the actual coronavirus infection?
Yeah, of course. Anybody like protective immunity, however acquired, contributes to herd immunity. But even with the massive number of cases that we see, realistically, only a very small proportion of the population has actually been infected with COVID-19. Certainly some are maybe between 5 and 10%, but certainly not more than 10% of the population. And I would think probably closer to 5 to 8%. So very few of us, unfortunately, actually have been infected with COVID-19. Well, I shouldn't say unfortunately. Fortunately, have been infected with COVID-19. So the level of protective immunity that currently exists is insignificant in terms of achieving herd immunity.
That makes complete sense. Is there any information on the vaccine increasing a person's chance of being infected with the new strain of COVID that is in Ontario?
No, no, because no. But it's still early days, right? It's hard for me to comment on that because I don't think we're specifically looking at vaccinated people and their risk of developing a COVID infection with B.1.1.7. We're just not looking at that at this point.
Okay. Are there any current recommendations as to waiting for a specific vaccine, or is it recommended to take the first available to the individual?
Yes, absolutely. I mean, I think whatever vaccine becomes available to you is probably the vaccine that you should get. At the end of the day, any vaccine, I think at this point, is better than no vaccine.
Great. I'll just I'll call out for any last questions with the group. These have all been really great questions, certainly, and thank you so much for taking the time to answer all of our questions. Long-term care herd immunity, how is this achieved or protected when the population changes?
I think you're right. I mean, you're introducing potentially new susceptible patients into a situation where there may be infected COVID patients, but hopefully by immunizing every single person and healthcare provider in congregate living situations like nursing homes will hopefully minimize the risk of that happening. That is, minimize the risk of an outbreak, maximize the risk of herd immunity.
Certainly. And is there any evidence that patients vaccinated for other vaccines, such as the MMR, Syndrax, etc., help with the immune response or disease severity of COVID?
Not that I'm aware of, actually. No, that's an interesting question. No, not that I'm aware of, no.
I want to really take the time. Thank you, everyone, for your amazing questions and interactions. It's certainly very appreciated. I want to thank you from the bottom of our hearts at the RTSO and RTs across Ontario, Dr. DiDiodato, for sharing your expertise and super applicable and relevant information for us. We're all very appreciative. There are so many chats coming in now just talking about how amazing you are, how appreciated appreciative we are how timely this is. So thank you very much. And I want to give a shout out to Sue Jones, who is our past president of the RTSO, who actually arranged this seminar today. So thank you very much, Sue, for leaning on your contacts and having Dr. DiDiodato share his knowledge and expertise and with us today. So thanks again. Thank you very much. We're super grateful.
Yep, thank you, Paula, and all the RTs, please take care, because I mean, I know how dangerous your jobs are. So my wishes for your safety. You guys are always in my mind.
It's very, very kind of you to say so. I will say that the webinar will be posted on the RTSO website under the links. And I will take full accountability and apologize for the technical issues at the beginning of this session and the beeps you may have heard throughout. Although they weren't as annoying as vent alarms and patient monitoring alarms, I realized they were a bit of a distraction. So my apologies from my end. That was my fault. Thanks again, Dr. DiDiodato. You're a rock star. What an amazing session. And thank you to all of you RTs who are doing what you do for patients across this province. Thanks and have a great day. Stay safe.
Have a great day, everyone.
Bye.
Bye.